Hey everybody, today we're going to be talking about left bundle branch blocks. Left bundle branch blocks occur when the impulses that travel through the left bundle gets interrupted. Now this usually occurs in the setting of a diseased heart, but it can rarely present in patients who have a normal heart. Now because of the block there, this will alter the activation of the ventricles that result in characteristic changes on the surface ECG. Now recall that the AV node divides into the left and the right bundle branches. The right bundle branch will depolarize the right ventricle, while the left bundle branch will depolarize the left ventricle. What's really important right now is that the left bundle branch gives off a septal fascicle. This depolarizes the interventricular septum. Now in order for you to understand the surface ECG changes, you have to know the normal QRS complex. The QRS complex represents ventricular depolarization, and because the interventricular septum is receiving impulses from the left bundle branch, right here, the wave of depolarization is going to be from the left to the right in this direction. Now this will generate a positive R wave within lead V1 and the right-sided leads, and it will generate a negative wave within the lateral leads or V6, hence you get a Q wave. Now following this, each bundle branch will depolarize its respective ventricle. Now right ventricular depolarization results in a wave that spreads into this side towards V1, and left ventricular depolarization results in a wave of depolarization that spreads this side towards V6. Now because the mass of the left ventricle is way bigger than the mass of the right ventricle, the net vector will be towards the left. Now this will generate a negative wave within V1 or the S wave and a positive wave within lead V6, the R wave. Now if you understand how the normal QRS wave is formed on the surface ECG, you can appreciate the changes that occur within the left bundle branch blocks. Now since the left bundle branch is blocked, it can no longer provide impulses to the septum. So the septum will be activated from the right ventricle. The waves of depolarization will be towards the left from this side because it's receiving impulses from the right bundle. Now this will result in an initial negative wave within the right-sided leads or lead V1 or a Q wave, an initial positive wave within V6. Then only the right ventricle will be activated. Because the left bundle branch is blocked, the left ventricle will not be activated yet. So the second wave of depolarization will be that of the right ventricle towards the right side. Now this will generate a slight positive wave within V1 and a slight negative wave within V6. So you can see this is the small R wave that's generated within V1 and the small S wave that's generated within V6. Now this may or may not be present depending on whether or not the septal depolarization overwhelms the depolarization of the right ventricle. Now after that, the left ventricle will be activated and you get a wave of depolarization that spreads towards the left side. Again, this will generate a negative wave within the V1, that is the S wave, and a positive wave within the V6 or an R prime wave. Now because these impulses are spreading within the left ventricle not via the fast Purkinje fibers, but rather through the slow gap junctions, this will result in a very slow ventricular depolarization, making the QRS complex very wide because it takes longer to depolarize the left ventricle. So just to sum it up real quick, the septum will depolarize from right to left, and then the right ventricle will depolarize towards the right, and then the left ventricle depolarize towards the left. Now you can imagine how this will create a notched or a slurred R wave in lead V6, and the small notch may or may not be visible, so it can be just a wide R wave. And in lead V1 you get this QS complex like this, with or without the small R wave. Now notice that because you don't have a terminal force that is towards the right, you cannot develop an S wave at the end of V6. V6 is mainly just a big, wide, slurred R wave. And because the septal activation is reversed, there is loss of septal Q waves that are visible within leads V5, V6, AVL, and lead 1. So you can't have Q waves within left bundle branch block except maybe in lead AVL. And the reappearance of Q waves within the lateral leads may indicate a septal infarction. Now, because of depolarization abnormalities, the repolarization will also become abnormal in left bundle branch blocks. This will result in ST segment and T wave abnormalities. Now, usually this results in ST segment and T waves that are facing in the opposite direction of the QRS complex. So for example, if you get a positive QRS complex, you can get ST depression and T wave inversion. And if you get a negative QRS complex, you can get a ST elevation and T wave that is upright. This is referred to as ST-T segment discordance, meaning that the ST segment and T wave are in the opposite direction of the QRS complexes. Now these are usually normal changes in left bundle branch blocks, except when the ST elevation is too excessive. You can, however, also develop normal ST-T positive concordance, meaning that if you have a positive QRS complex, you can have ST elevation and upright T wave. Now, this may be normal, but it can also be pathological depending on the clinical circumstances. However, development of negative concordance, meaning you have a negative QRS complex along with ST depression and T-wave inversion, now this usually indicates there's some sort of pathology going on, like an ischemia or something. So always look out for those changes. So always look out for ST segment and T-wave abnormalities within left bundle branch blocks. And because of that, it might be difficult to diagnose ischemia in the setting of a left bundle branch block. So let's take a look at this ECG demonstrating left bundle branch blocks. If you look at V6, you can appreciate that the QRS complex is very wide. This is probably about 4 small squares, and the normal QRS complex should not exceed 3 small squares or 120 milliseconds. Along with that, you can also appreciate there's slight notching right here with lead V5. And lead V1, you get a deep QS complex like this. You can also see that we don't have any Q waves present within the lateral leads like V5, V6, AVL, and lead 1 because of the loss of the normal septal activation. You can also appreciate the STT segment abnormalities. In lead V6, we have ST segment depression and T-wave inversion, but the QRS complex is positive, so we have STT segment discordance, which is usually normal in the setting of a left bundle branch block. And in lead V1, we have a negative QRS complex, an ST elevation and T-wave that is upright. So those are the STT changes that you can see in the setting of a left bundle branch block. So you can say that this patient has a left bundle branch block because of the wide and slurred R wave within the lateral leads, a wide QRS complex that exceeds more than 3 small squares, the absence of Q waves with the lead V5, V6, and lead 1, and also the time to the peak of the R wave is also prolonged. This is the time from the beginning of the R wave up to its peak, and if it's more than 1.5 small square, then you can say that the R peak time is prolonged. And this is how you can make the diagnosis of a left bundle branch block. You require a wide QRS complex that is more than 3 small squares or more than 120 milliseconds. You need a broad notched or a slurred R wave within the lateral leads, usually lead 1, AVL, V5, and V6. And also you need absent Q waves within the lateral leads. However, AVL may show a narrow Q wave normally. Also, the R peak time, which we just talked about, is also greater than 60 milliseconds. There's more than 1.5 small squares. It leads V5 and V6. However, it can be normal and leads V1 to V3 if you see an R wave in there. And that is how you can diagnose a complete left bundle branch block on the surface ECG. Thanks for watching.